Hello, everybody. Welcome to the Two Nurses, One Podcast, I guess, right? It doesn't really roll off the tongue, but I like it. Two Nurses, One Podcast. I am one of your hosts. My name is Chris. I am a master level nurse majoring in clinical education. And then, of course, with me is my longtime friend and colleague, Dan. Dan, tell us a little bit about yourself.
Hi, guys. So my name is Dan Clinton. I'm a registered nurse. I specialize in pediatric home care, and I'm also a professional nursing tutor. So I help people who are still in nursing school, and then I help people who have graduated past the nursing board exam to become licensed practical nurses and registered nurses.
Yes, absolutely. Lots and lots of experience. And I'm a little bit jealous because you're way more up on your A&P than I am. So as we kind of talk about things, you're going to kind of be the go-to. But I will certainly be there to throw in as much clinical information and experience as I have. So basically, this is Two Nurses, One Podcast. What we aim to do here is we try to take healthcare topics of the day, break them down in a deep dive format, and kind of put them into more of a layperson terms that not only healthcare professionals can understand and enjoy, but regular everyday people too. And you might even just learn something new. So that being said, one of the first things we want to talk about is vitamin D. It's something that's been a big topic in the healthcare literature, not only as of recently, but I would say over the last 10 or 15 years. Something that Dan has actually done quite a bit of extensive research in, and I think it's an absolutely fantastic topic to be starting off with. So without further ado, Dan, why don't you tell us a little bit about the background of vitamin D and why it's so important?
Sure. So vitamin D is a fat-soluble vitamin, and it's needed to absorb calcium in the small intestine. And so the fact that it's fat soluble is actually pretty important for a couple reasons. So, vitamin D is best absorbed when placed in an oil based gel cap. So, a lot of studies and a lot of vitamin D just came in a regular tablet. And that really wasn't bioavailable. It had inconsistent and absorption and wasn't absorbed well. So the fact that it's a fat soluble vitamin, that explains why if you're supplementing with vitamin D, you'd really want to take it in an oil-based gel cap. Now, uh, we make vitamin D when our skin is exposed to UV light. But think of Eskimos, for instance. You know, they're at a very high latitude. How did they get their vitamin D? They actually would get vitamin D from whale blubber because it's fat soluble. So things like salmon are some of the few foods that actually have it. So being fat soluble, it would get stored in whale blubber. So
Whale
if
blubber
you're
sounds
ever really
delicious.
vitamin D deficient and you can get some cheap whale blubber, there's a place down on 114 in no, I'm just kidding.
I
And
would
then
imagine some of the Asian markets in town, though. No.
John, John's Whale Blubber Emporium. There's always protesters out there with signs.
I can't imagine why.
And so normally we would make vitamin D, but we do also get it from a couple food sources. And then one interesting sort of facet is if we make vitamin D when our skin is exposed to UV light, we don't really know how quickly it's absorbed from our skin into our bloodstream. So one potential factor that could be actually contributing to vitamin D deficiency is soap. So we actually get so much less sunlight. At least I do. I don't get to bathe nude as much as I once did or wish to do these days. But we really don't get as much sunlight. You could make an argument as nature expected if we're taking an anthropologic perspective. And especially if humans evolved, in equatorial Africa and now living up here in Massachusetts, we're just not getting that same kind of sun exposure. And that's part of why there's such a large prevalence of vitamin D deficiency.
In fact, Dan, can't you track specifically by what point of latitude you are on the planet?
Well, so what's kind of interesting is that there are associations between latitude and vitamin D deficiency. There's also associations between lots of autoimmune diseases and latitude, which we'll come back to later. But it's not a perfect association just because we've all been told that we have to really cover up our skin to protect against skin cancer. So even in places like New Zealand that you would think just based on latitude would have very high vitamin D levels, if there's been real intensive sun campaigns, then you actually end up with vitamin D deficiency. So even places like Iran and things like that, where it's so hot you really can't be out in the sun and they're covered up, you actually don't get perfect associations between latitude and vitamin D. And that's something we'll come back to when we talk about COVID a little bit later as well. So um, the problem is, suppose we actually go sunbathing, and now our skin makes this vitamin D and it's stored in the oil in our skin. It might take up to 48 hours for that vitamin D to really get into our bloodstream. So then we immediately wash with soap. Are we actually pulling away
Mm.
some of that vitamin D deficiency? So that's one of those things that would be tough to actually sort of study empirically, but that makes a little bit of logical sense. So if you are going to the beach and you want to harness that vitamin D, just use soap where you need it on your groin and on your axilla. Does that make sense?
Yes, yes, continue to be dirty, dirty people. I love it. Well, no,
Well,
there is something to be said for allowing the natural oils to kind of do their job. Like you said, from an anthropological perspective, people weren't bathing every day, especially with these harsh cleansers and chemicals. It might not be unheard of to go several days, maybe even a week in between bathing historically.
and then, does your upper arm really get
Mm.
that dirty? Does
Right,
it merit
right,
your
right.
your body wash?
Let me back up. I'm not advocating to stop bathing, people.
Yes, he had a brief phase in college. We had an intervention, and his
I'm
hygiene
better
improved
now. I'm
dramatically.
better
And
now.
now he is the master's educated, successful man we've all grown to love today. So, and who didn't have a weird phase in their 20s? So no judgment. So, one other important facet of vitamin D being fat soluble is that we store fat soluble vitamins in our liver. And
Mm.
so, long before vitamin D was discovered, uh, they found that cod liver oil, the oil that was made from pressing a codfish's liver, would actually treat a disease called rickets. So, rickets is kids would get these weak bones and they'd actually get bow legs. The adult version is called osteomalacia. And long before chemists actually identified what vitamin D is, it was discovered that cod liver oil could actually fix rickets. So it was one of those where sort of the food or the food product was discovered to be the medicine before chemists had actually figured out the substance within it that was
Hmm.
effective. So that's why it really is important to understand that vitamin D is a fat soluble vitamin. Now, vitamin D, one of the reasons Chris and I really wanted to kind of address this early is it does seem like it's a very controversial topic. Like there's a
Absolutely.
variety of opposing opinions and contradictory viewpoints. And just one example that I thought was kind of funny that highlights this is there was a big study that we'll talk about a little bit more in depth later called the VITAL study that studied 2,000 international units of vitamin D3 with or without fish oil. And when it was published, like literally on the same day, on Yahoo News, the article headline was Fish Oil Cuts Heart Attack Risk with Vitamin D. And then NPR, reviewing the same study, wrote Vitamin D and fish oil supplements disappoint in long-waited study.
So a lot of
so you can see,
variability in the interpretation of those results.
you
Yeah.
can definitely see why people are kind of confused. So
Yes, absolutely.
one role of the nurse, we're the ones who are doing the discharge planning. We're the ones who are supposed to be providing a lot of patient education. And really, one role of the bachelor educated nurse is to really be a keen discerner of information. And then to try to translate that to make it a little bit more accessible. So we have this very controversial subject, and we're hoping to really dig in deep, and at the very least, you'll leave understanding it to the depth that we understand it. So I do have one slide here. I have a couple slides. Did that work? Success?
Absolutely. I can see it perfectly.
At some point, you guys will all see my like, how do I do this face? Zoom has
Again,
made
we're
me
nurses. We're not high technologists.
Zoom has made me self-conscious. All of my tutoring is online now, and I made the mistake one day of like taking a bite of a bagel, and I saw what I look like while eating a bagel, and I felt so hideous. Like, how could anyone love me? So, and when Chris first had the idea of doing this podcast, he suggested and doing this podcast, and I was like, oh, do you want to do video? Do you want to do audio? And he said, oh, let's do an audio podcast. We're not too bad looking guys, which I think is cute. Yes, that's true. I don't think we're bad looking guys. If we were walking down the street, I don't think people would stop and comment and be like, those are two unattractive men. But just like in the age of Instagram influencers and stuff like that, like our rugged sex appeal is what's really gonna
Oh
turn
yeah,
this
I don't see us turning into influencers
Right.
for our attractiveness. No,
All
absolutely
right,
not.
yeah, it's
Maybe
the
for our
brain and-
intelligence, we can hope.
But well, also in your 30s, aren't women looking more for intelligence at that? Aren't they just like, I would rather have someone smart with a good credit score?
That's what I
who'll
keep
be
telling
nice to
myself,
my
Dan.
kids.
That's what I keep telling myself.
Me too. It helps me sleep. So. All right, so let's look at why sort of vitamin D is so controversial here. So there's no real consensus on what blood level is sufficient and certainly not optimal. It's kind of easier to pin down what's deficiency versus not deficiency, sufficiency. Really a lot trickier to figure out what's optimal. So we'll talk about that a bit. Now, the skeletal benefits are clearly established. Everybody knows vitamin D makes you absorb calcium. We need calcium. We store it in our bones. That's not actually its primary function. We need it in our blood so our nerves can communicate with our muscles. And that's why if you're not ingesting enough calcium or vitamin D, your body will release a hormone called parathyroid hormone to take the calcium out of your bones. And so that's one thing that you actually have to look at is there's a condition called secondary hyperparathyroidism, that if you're vitamin D deficient and unable to absorb that calcium, your body starts to pull it out of your bones. So your blood calcium doesn't dip low. Instead, your parathyroid hormone level goes high because your body will eat your bone matrix away to nothing if it has to choose between weakening your bones or getting low blood calcium, hypocalcemia. And then there's a clear association between vitamin D deficiency and a whole host of diseases, but association doesn't equal causation. Association is just one of many criteria needed to establish causation. So that's part of why I think this is so controversial. And hopefully we'll dig into these concepts and get a bit of a better understanding.
And part of as your point about being a bachelor's level nurse is having that skill to actually deep dive into these studies and determine, okay, is this even a good study? Are these results valid? Does this translate clinically? So you're absolutely right when you talk about causation not being correlation not being causation. That's such an important factor, not the least of which when you talk about vitamin D, which as we'll talk about, vitamin D has been associated, low vitamin D level has been associated with a number of conditions, and then it becomes a chicken and the egg factor. Are they having this disease because they're deficient in vitamin D, or is part of the disease process lowering their vitamin D? These are all things we need to tease out.
And so one other concept, coming back to why vitamin D being fat soluble, is being fat soluble, vitamin D can get essentially like sequestered in fat. And so you do see that there's much higher rates of vitamin D deficiency in obesity because that vitamin D has gotten stored in the fat cells. It's not circulating in the blood. It's not available. And also that's why you need to really push the doses sometimes in obese clients, easily needing 2 to 3 times as much vitamin D as normal. And then that sort of leads to the challenging question, could vitamin D be associated with these diseases, but more so because it's serving as a surrogate marker for other conditions.
Right.
It's serving as a surrogate marker for obesity. And then
the bigger part of the picture.
If we make vitamin D when our skin is exposed to UV light, then it would make sense that African Americans, people with darker skin pigmentation, they have more melanin in their skin, so they're not getting as much of that UV light, have higher rates of vitamin D deficiency. So it is very difficult to tease out association from causation. And there have been some problems that I have with some of the studies that attempted to do so. And I know we'll dig into that a little bit deeper in a bit.
Absolutely.
So just to talk a smidge more about the UV light and how we actually make our vitamin D. So our skin gets exposed to UV light. There's 2 types of UV light. that make it through our ozone layer, UVB and UVA. And it's when our skin is exposed to UVB light that we make that vitamin D. And then again, eventually it gets brought into the bloodstream. Now, UVB long-term increased exposure is associated and very likely causal with an increased risk of skin cancers like basal and squamous cell carcinoma. And that's why dermatologists, fearful of skin cancer, said, oh, we really should be protected from sun at all times. We should wear sunscreen at all times if you're ever out. The problem with that is, was that a bit myopic?
Hmm.
Was that scorched earth and really just focusing on the one variable of skin cancer and actually ended up causing vitamin D deficiency, which could potentially have actually worse ramifications. So, what's the balance between how much sunlight we should get to make the right amount of vitamin D versus not creating unnecessary risk of skin cancer? That's a question that I don't think there's any sort of objective answer to. It's just a matter of opinion.
And
If we
Dan,
were
just to clarify real quick, sorry to cut you off there. You said UVB specifically is associated more with the basal cell kind of skin cancers and less with the melanomas, correct?
So that's kind of a tricky one. So here's one of the problems. UVA light seems like it penetrates our skin deeper. And that
Mm-hmm.
might be more causal in melanomas, which make up a very small percentage of skin cancer, but are almost exclusively, like more than 95% of skin cancer mortality. And so another one of the problems with sunscreen is when you read of the SPF, the sun proof factor, that only applied to UVB light.
Hmm.
So if you were dealing with a sunscreen that worked well at preventing UVB but not UVA, you might go out in the sun and you don't get a sunburn because it's the UVBs that cause sunburn and that also create the vitamin D. But the whole time your skin was getting bombarded with that deeper UVA light. And so that's why with sunscreens, you want something that's broad spectrum. That means it blocks both UVA and UVB.
So you're saying there's a window of benefit where, say with tanning bed technology, where we can actually modulate the amounts of UVB versus UVA and emphasize that UVB, get health benefits, and be less harmful than total sun exposure.
They do make some super fancy, tanning beds that are specifically for that. That last I checked
Interesting.
were like thousands of dollars, or it's like I'll just take the pill in the winter.
Right, right.
But yes, they do make that. But it is, to be fair, it's tricky to figure out what would be the right balance of sun exposure.
Hmm.
To
Interesting.
me, to say, oh, we should be out of the sun at all times. Uh, that just doesn't make logical or anthropologic sense. If we think that humans evolved in equatorial Africa, well, then that really explains why we have this divergence in skin pigmentation. People who are more proximately of African descent would have darker skin because living in equatorial Africa, darker skin with more melanin, a pigment to block some of that UV light, would create the better balance of still getting enough UV light to make vitamin D without getting too much, increasing our risk of skin cancer. If you're living in Ireland, you can be pale and probably freckly, but at least pale, because you want to have there's less UV light up there, so you want to get more of it in to make the vitamin D. So that really explains where the differences in our skin pigmentation come
Absolutely.
from. And so uh, there's varying recommendations. Dr. Michael Holick, he's a professor out of Boston University. He's one of the big vitamin D gurus. When he actually discovered the active form of vitamin D in the blood. And when he first started, recommending that people try to get really small controlled amounts of sunlight daily, there was huge pushback from dermatologists. And
Those
so that
nasty
debate
dermatologists.
still exists. Well, not, I'm sure they're wonderful people. I don't want to
They
stress
mean
that.
well. They mean well.
They do have high rates of vitamin D deficiency, though, actually. They actually have lower than average vitamin D levels. One study found, I think the average was like 35 nanomoles which is what you'd have to like divide by 2.5 to get milligrams. They had high rates of vitamin D deficiency. And so, uh, you know, if we were to apply a little bit of a common sense measure, according to Dr. Michael Hollick, here in Massachusetts, if you spend like 20 minutes in a bathing suit down on the Cape, you make the equivalent of 10 to 20,000 international units of vitamin D daily. So, I mean,
So it doesn't take
how
much, in other words.
it doesn't, and how much to make a lot of vitamin D. And so, how much sun should we get? Well, we should try to get a little bit of sun and get out before you get a sunburn, right? That like minimal erythemal dose. So, you'll still see conflicting reports. There are still physicians who would say, "Oh, you just need 5 minutes of sun on your face every day." I don't think that's evidence based or commonsensical. Um, I make a proactive effort to try to get some sun on a summer's day over a good body surface area just for 10, 15 minutes. I want to get out before I burn. But, to me, our body would have natural mechanisms to tell us, hey, we got too much sun, and that would be a sunburn.
Right.
So you want to try to get a little bit of sun daily to find that correct balance. And then um, when we want to get a good amount of sun exposure, again, if we're perpetually covered up, then we're just not going to make that vitamin D. And as we age, our body actually loses the capacity to make vitamin D. So even in elderly, that sun exposure might be inadequate. And one reason why you could postulate our body starts to make less vitamin D is that one of nature's mechanisms of kind of trying to kill us off. After we've procreated, evolution is like, I don't have any use for you anymore. I want old people around to babysit my kids. My grandparents are very important. But you can see how, that it's, some people have postulated that that's one mechanism of sort of setting a natural clock of being like, all right, buddy, there's only so long you got on this planet, that you lose the ability to make that vitamin D. So unfortunately, I do think the sun, like the source of all calories in our like solar system, that the sun has gotten a little bit of a bad reputation. A little bit. It kind of needs a new advertising campaign.
We need to hire a publicist, get a new PR campaign going.
Well, I picture like somebody like
the sun is not the enemy.
Big, rosy cheeks, like, Billy, did you get your 10 minutes of sunshine today or something like that,
Oh, shucks. I haven't gotten it yet.
I feel like Don Draper, like everything's better with a scoop of sunshine or something.
There you go.
Sunlight, Earth's primary source of energy. So, one of those, something like that would stick. And so we do want to find that balance of making vitamin D without increasing our risk of skin cancer. And that's still a contentious matter of debate between the people who really buy into the risks of vitamin D deficiency and those who really aren't convinced and are more worried about skin
Dan,
cancer.
you mean to say life is about balance? This is shocking. Yeah. This is absolutely shocking.
Well, but just, in medicine, we are prone to systemic myopias.
Yeah, we like to overcorrect for one problem at a time.
So you fix one problem and then
you go on to the next. Yeah,
multiple others. And so I think my personal read is that would be a case to really be scorched earth and say we should avoid the sun at all times. That just doesn't make logical sense to me.
No, absolutely not. The giver of all life. Yeah, you should avoid that probably.
All right, and so. Just to talk a little bit more about the rickets and vitamin D and sort of the history of vitamin D. So what I find interesting about vitamin D, again, it wasn't until like the 1930s the chemists discovered what vitamin D was. Reports of rickets, kids getting bow legs, go all the way back to the 17th century. And it was German doctors who figured out that cod liver oil could actually fix this vitamin D deficiency. And then they figured out.
How do you suppose they landed on cod liver oil? How many things did they try before that?
Probably a bunch. But the cod liver oil contains, I think it's like 1,320 international units of vitamin D. per tablespoon. My grandfather was tortured with cod liver oil, and my grandmother took great pride when
In torturing him?
studies sort of validated that it really was good for you, you know. But back then, people would, you know, every day, my grandmother would make him take his spoonful, not in an
Oh,
oil-based gel cap, just a spoonful
just
of
straight
cod
out of
liver
the
oil.
liver, straight out of the liver. Just squeeze it right out.
But it, you know, it definitely did work. And yeah, so it's 1,360 international units per tablespoon. So they found that 1 to 3 tablespoons of cod liver oil could actually reverse rickets in children.
Oh, wow.
And then later, chemists discovered vitamin D. And there are a couple different forms of vitamin D. So first, we make vitamin D when our skin's exposed to UV light. Then it undergoes one chemical change in the liver, and then it undergoes a second chemical change in the kidneys. And that's important because when people have chronic kidney disease, as it progresses, very close to 100% of them will develop secondary hyperparathyroidism because they're not able to make that active form of vitamin D.
Mm,
So they actually are prescribed
mm.
the already activated form of vitamin D. The most common one is calcitrol. And uh,
Yes.
the different types of vitamin D, I don't want to spend too much time on it, only because it doesn't make sense to me a lot. But there's vitamin D2, which is ergocalciferol, and vitamin D3, which is cholecalciferol. They make vitamin D2 by exposing mold to UV light. So it's like the plant form. And
Hmm.
they make vitamin D3 by exposing lanolin, sheep's wool, to UVB light. And so
Hmm.
that's really like the animal form.
Hmm.
And D2 is available by prescription, D3 is available over the counter. But you do still see physicians using vitamin D2, and I don't really know why. Like,
Do you
I
think?
knew I would be asked why vitamin D2 over D3. I have no idea. It seems like vitamin D2 doesn't last as long, it has a shorter half life in the body. It's not quite equal in terms of dosaging. So
I
you do
wonder
still
if the
see.
vegans of the world have a stance on this
Well,
issue.
so that's legit. You know, like if you had somebody who was sort of opposed to animal products who didn't want to take D3, then use D2. But that's really the only circumstance that would make sense to me why you would pick D2 over
Over
D3.
D3. Hmm.
And so another sort of interesting facet is when they started pasteurizing milk, it destroyed vitamin D. And so the vitamin D that's presently found in milk has been put back in there. So when they pasteurized milk, they didn't know it, but they were destroying vitamin D. So then there was
Oops.
another explosion of rickets. So now they go back and they actually put vitamin D back in milk. But we can't assume that all dairy products have vitamin D. Like they don't put the vitamin D in milk for the milk they're going to use to make cheese. So you can't just
Right.
always assume there's vitamin D in all dairy because it's destroyed by the pasteurization process.
Right. And I don't know if in the process of making cheese in with the various fermentations and cultures and things, if that would naturally destroy it as well. I'd be interested.
So the milk has 100 international units per cup, at least here in America. I think that actually varies internationally. I guess one benefit, one reason why people used the vitamin D2 was they would do these real big doses once weekly,
Hmm.
like 50,000 IUs of vitamin D2. And I guess that makes it easier in terms of compliance. But that doesn't really make sense to me. I wouldn't want to get all my sunlight once a week. Actually, one really depressing statistic that I learned, I think, back in nursing school was that we get about 80% of our sun exposure before age 18.
Wait, what? Say that
Isn't that
again?
kind? Isn't
Before
that kind
age
of
18,
yeah?
80%?
Isn't that kind of soul crushing when
Wow.
you think of adulthood?
That
Well,
is
think
like,
of, you know,
are people just
summer
not going
camps and things
outside
like.
anymore? Like, what's
Well,
going
you
on?
know, you're not out as a grown up. Most people aren't, unless you have a job where you work outside, and those people have
I
higher vitamin D
guess.
levels. But you know, I mean, we're just not spending whole days outside like at a day camp,
That
you know,
just
or
seems like
something
a
like.
big drop off.
It's a bad. I remember learning that when I was like 20, and I was like, oh God, that's terrible. And then
No
I
wonder we're
remember
so
being
sick.
well, I was at a conference about asthma when I was 26. And then they said, oh, you know, and lung capacity starts to decrease after age 26. And I was like, ah, crap. here we go. It's going down. So, such is life, right? Uh,
Or death, and
Dumbledore
more
in Harry
appropriately.
Potter, Dumbledore shrugged as if age has its compensations. So what can you do? But
Yeah, there you
uh,
go. But you make more money, you
it
can
was
do more fun
sad,
things.
sad even at 26 to learn my lung capacity was going downhill. So, and then sarcopenia, we're losing muscle too. So
Hmm.
I've started I'm going to my boot camps again to try to maintain here.
I've
So
been trying to work the home gym aspect as much as I can, so I have various devices and things that I've been using.
you know, you don't need a lot of equipment. Do
Just
push-ups
basic
to failure.
resistance training
Yeah,
stuff.
yeah,
Yeah.
I like resistance
Yeah.
bands.
Yep.
That's a podcast for another day. I'm sure we'll get
Oh,
to
we'll get there. We'll get there.
that. And so, um, the vitamin D had to get added back into milk. And some places still use vitamin D2 for that. Some still use vitamin D3. And so just sort of two controversies that just don't make any sense to me. Why would you rather use the plant form over the animal form? I don't really understand the rationale why someone would opt for D2 over D3. I don't really understand weekly regimens of very high
Yeah.
dose versus a daily regimen. And I just don't understand why anyone would give vitamin D not in an oil based gel cap, because you just don't get that same level of absorption. You'd have to like take it with olive oil, or you might get some absorption if you eat it with a fatty meal, but you just get so much better absorption when you take a vitamin D supplement in an oil B gel cap. So I would definitely, my read of the data is that D3 is better than D2, and that a daily regimen of an oil-based gel cap would be the way to go about supplementing with vitamin D.
Absolutely. And everything I read, it seems like the health benefits of proper vitamin D levels are really achieved when you have a normal level as opposed to getting sick then trying to catch up to a normal level. Does that make sense?
Also, so primary prevention is when you're trying to stop something from ever occurring, and then secondary prevention is treating it. So like a lot of
Right.
autoimmune diseases are associated with vitamin D deficiency. That doesn't mean that vitamin D in and of itself is causal, but like type 1 diabetes, for example. Type 1 diabetes occurs when there's autoimmune destruction of the beta cells of the pancreas, and those beta cells produce insulin. It shows up in children and young adults. And after a honeymoon period, they'll always need injections of insulin. They'll be insulin dependent because their pancreas just doesn't make it. And nobody knows exactly what causes it. Is it viral? Is it autoimmune? Is it genetic? There's higher rates if you have a
Mhm.
first degree relative. It's some combination. So, you know, vitamin D in and of itself probably isn't sufficient. Vitamin D deficiency by itself isn't really sufficient to cause to cause type 1 diabetes, but does it create an environment in the body where autoimmunity is more likely to occur? Or does it make you more prone to get a virus that then triggers it, or a response to some sort of protein that then triggers it? And so what's interesting about autoimmune diseases, there is a real strong association with latitude, but also when people from developing countries come here to the US, their rates of these autoimmune diseases then increase. So it
Interesting.
does seem like it's something about the way we live,
So some sort of
more so than
environmental
just
or
purely genetics.
so okay, so either like a lifestyle or environmental factor or a combination thereof.
And it would also be fair to think that you wouldn't really expect the same dosages to work for primary prevention as for secondary prevention.
Well, it
So
certainly
if you're
seems like that you get the most benefit out of primary prevention when it comes to vitamin D supplementation.
Well, I mean, the hope would be to try to prevent these
Mhm.
diseases. And then if you were going to use it like as an adjunctive treatment, I know you're going to talk about COVID a little bit later, you know, the dosage would likely need to be higher for treatment versus
Mm,
prevention. Does that make sense?
absolutely.
All right. Um, and so when we're thinking of vitamin D, you know, those skeletal benefits are super well established. It's all the other stuff, you know, the fact that it modulates cell growth, that it helps with gene expression that then regulates all these other things, that it
Mm.
reduces inflammation, that it helps regulate the immune system. There's vitamin D receptors on B and T lymphocytes. All that stuff is still relatively new. So the bone stuff is well established. All these other roles, because there's vitamin D receptors all over the body, that stuff is still fairly new and not fully understood. And that's part of why we have these sort of opposing camps where we still don't really know exactly the blood level where we get the benefits, these extraskeletal benefits, and the mechanisms still aren't fully understood.
Yeah, and it seems like those mechanisms have been mostly researched in a lab setting. So, like you said, a number of cells in our body systems have those vitamin D receptors. There's some literature about how vitamin D has a direct effect on the renin angiotensin system, certainly as a check and balance to certain inflammatory measures as well. But again, this hasn't really been established clinically. So, you can't really say, like, oh, okay, someone's having these mechanisms, these processes, let's load them up with vitamin D to counteract. Can't really say
So
that at this point,
Well, so the way that you would do that is with randomized controlled studies. And
which,
we'll talk about
right.
some of the attempts that have done that and sort of some of the problems with it. Even before we jump into that, let's just talk, I would say, a little bit sort of about sunscreens and sunlight. So we know that we
Absolutely.
make, vitamin D when our skin is exposed to that UVB light. We do need to find the correct balance of that. And like I said before, if you use a sunscreen that isn't broad spectrum, that just blocks the UVBs but lets the UVAs go, you're not going to get a sunburn telling you to get out of the sun. Those might actually be worse than no sunscreen at all. And so there's a group called the Environmental Working Group that did a lot of research into sunscreens, and they kind of surprised themselves with their conclusion, which is always good for scientists to do. You're supposed to be able to be surprised. But they found that mineral sunscreens were actually safer than chemical sunscreens. So mineral sunscreens really just coat the skin and reflect the UVB light, like zinc oxide and titanium dioxide, whereas chemical sunscreens absorb the UV
Mm.
light. And even like 10 years ago, the Environmental Working Group expressed concerns that these chemical sunscreens could get absorbed through the skin. And they never had actually studied whether like blood levels of these chemical sunscreens after use. And so finally, just recently, the government, which doesn't normally do those studies, but they actually did studies themselves, and they found that even after one application, the blood levels of a lot of these chemical sunscreens was much higher than the pretty arbitrary threshold that they had set
Hmm.
for safety anyway. So I give the Environmental Working Group some credit that it seems like their concerns were validated, that the chemical sunscreens do get absorbed into the skin.
Hmm.
So for my money, the best sunscreen would be using zinc oxide. I like zinc oxide more than titanium dioxide because zinc has a physiologic role in the body and titanium doesn't. The zinc molecules are spherical. The titanium dioxide are like tiny little rods. And you want to get non-nano zinc oxide because to make sunscreen clear and smooth, they make these nano-sized particles that are like smaller than a virus. And there's concern that those might get absorbed. So really the best sunscreen is like the 1950s, lifeguard with the white zinc oxide on his nose. But that really does seem to be the safest sunscreen. And we'll actually put a link to the Environmental Working Group. They rate sunscreens on a scale from 1 to 10, 1 being the safest, 10 being the least safe. And some of the products have gotten better. They're expensive, the non-nano. They're kind of goopy and thick. Badger is the brand that I buy. They make a clear zinc oxide that's non-nano. That's not super clear, but it's clearer and it's less goopy than the old ones. And it is expensive, but that's what I put on my kids. So,
Goopy.
and then they do make spray sunscreens. Now, spray sunscreens, they've expressed concerns. Oh, are we inhaling some of this? the safest spray sunscreens, the lowest rated ones, were rated a 3. But as someone with 2 children, gooping everybody up to go to the pool or something, that really is a lot of work. So at the very least, if a parent wanted to use a spray sunscreen on their kids' arms and legs and then use a regular sunscreen on their face, no judgment on my part. And so there were some spray sunscreens that were rated 3. So if you're going to use sunscreen, which would be recommended if you're going to get prolonged sun exposure, certainly longer than that typical amount at which you would get a sunburn, the safest sunscreens appear to be those that use mineral sunscreens like titanium dioxide and zinc oxide. And I'd really recommend checking out the Environmental Working Group's list, because there are some sunscreens that have all the good ingredients, but they actually have cruddy ratings. And it's because the Environmental Working Group thought that they overestimated their sunproof factor. So there really isn't like, now you see these crazy SPFs like SPF 80, SPF 60. You really can't buy any of those SPFs, really believe any of those claims really greater than 30. So there's deserved skepticism that like SPF 50 really is much better than SPF 30 or something like that. But an SPF 30 sunscreen with zinc oxide for prolonged sun exposure, that would seem to be the safest sunscreen and give you good, broad spectrum protection from both UVA and UVB. And it doesn't have those chemical sunscreens that get absorbed through the skin and might potentially, we know they now get absorbed through the skin. There isn't really great evidence of direct harm, but I don't want to wait till there's evidence of direct harm. This goes back to that sort of fundamental association versus causation conflict. So with chemicals, our system has to be reactive. Like, chemicals are kind of released, and then we start to note there's an association between these chemicals and a disease. But the manufacturer can just say, well, it's only association, it's not causal. And we can't deliberately expose somebody to something we think is harmful. So you can't just say, oh, well, let's just load a bunch of kids up with oxybenzone and see if their hormones get screwed up. If you think something's helpful, you can ethically randomize 2 groups and try to say, oh, these groups are pretty much identical to the best of our ability. We're going to inject a variable or introduce a variable that we think will help one group and not the other, and study the differences between them. But you can't, cause harm. And so with our chemicals, we have this very slow moving reactionary process. So I wouldn't wait for some government group to now say, oh, it turns out that, the people that we kind of said were, nitpicking 20 years ago were right. These things are hormone disrupting. I feel strongly enough about it that I pay for the fancy sunscreen for my kids. So.
It's interesting. It's that same kind of legal loophole that the big tobacco companies have used for years to kind of stay in business. You can't randomize a controlled trial where you force someone to smoke. You're looking for harm. So it becomes frustrating.
And it's very challenging in general to tease out association from causation. And I think we'll dig into that in a sec when we're sort of talking about some of the problems with the blood levels and some of the studies that have occurred. So why don't we jump in and start talking a little bit about some of these blood levels?
Let's do that.
So there is now a blood test for vitamin D, the kind that you would want to get. It's called 25-hydroxy vitamin D. It's the kind that floats around in our blood. It's a better marker of vitamin D status than other measures. General labs can do it now. And certainly, if somebody's having venipuncture and blood work done anyway, I'm of the camp, why don't you try to find out your vitamin D level?
Starting to see a little bit of that clinically, yeah. It is being done more routinely.
And certainly you see for autoimmune diseases, for the elderly, you're starting to see more people screening. But again, there's contradictory recommendations for that as well. And so there isn't a real consensus as to what blood level constitutes deficiency. So the Institute of Medicine defines vitamin D deficiency as blood levels less than 20 nanograms per milliliter, whereas the Endocrine Society, which is pretty well recommended, well respected, the The Endocrine Society set 30 nanograms as the minimum. So there's even some debate about what constitutes clear-cut deficiency, even just for bone health.
Mm-hmm.
And so the criticisms of the Institute of Medicine protocol was that when the IOM was developing their standards, they just said, since we don't really know enough about these extra skeletal benefits, we're really just not going to think about them at all when making our recommendations. And also, they based population averages. They made their decision based on population averages. But, you know, when you're thinking, you're not really factoring in weight, skin color,
Mm.
latitude. And so there's reason to be a little skeptical, in my opinion, of that 20 cutoff. And I would fall more into the camp. There was some studies that even showed you need levels of like 30 to 32 just to prevent that secondary hyperparathyroidism. That really levels less than 30 should be used to constitute overt deficiency. But again, there's definite debate on that one. And then as far as getting optimal blood levels or those extra skeletal benefits, yikes, you know, you've just got completely varying opinions. The Institute of Medicine specifically advises concern. They're worried about levels above 50, whereas a lot of physicians who are believers in vitamin D really recommend levels above 50. Uh, that when you get blood levels about 50, they believe that's really when everybody would start to store vitamin D. So in other words, like even at blood levels of 30 or 35, that's really that substrate is just being used as soon as it's brought into the blood. But that really just about everybody would start storing vitamin D up above 50. So the Vitamin D Council recommends blood levels of 40 to 60 nanograms per milliliter. And then the highest levels I've seen recommended come from like Dr. Mercola and Dr. William Davis, who got some mainstream notoriety for his book Wheat Belly. He really goes after processed grains and dwarf mutant wheat, this hybridized wheat we eat today. He recommends blood levels of 60 to 70. So there's this huge range where some labs, it might just say anywhere between like 20 and up to 100 or 150 is normal.
Hmm.
That's a pretty big range.
It's a pretty big
So,
range, yeah.
you know, as with anything, vitamin D could be toxic, but it's very hard to achieve vitamin D toxicity. There's a very wide therapeutic index. So the lowest levels that I found in the literature that were directly like shown to cause an adverse reaction was 88. That there was a case report of a client who got high blood calcium and calcium in the urine at blood levels of 88. Some labs use 100 as the cutoff, others use 150. The Institute of Medicine actually defines toxicity about 200 to 240. And even I was just reading, there was a case report of a child in Iran who had overdosed, taken some of those 50,000 international unit gel caps. That's one other criticism of those large dose weekly regimens. That much vitamin D in one gel cap could cause toxicity if it was inadvertently ingested by a child. And he had a blood level of 500, but still a normal calcium, and it resolved just without further treatment. So for acute poisoning, if it was very soon after ingestion, they would treat with activated charcoal. Otherwise, they just monitor the labs typically. So it seems like, at least for vitamin D toxicity, there would be bigger concern with chronically high levels than acute.
So it seems like
So
the ceiling is pretty high in terms of
it's very high. Now there have been contradictory epidemiologic studies. So epidemiologic studies are just sort of comparing trends between people, and so they're unable to establish causality. And you'll find contradictory epidemiologic studies about just about everything. But you know, lower rates of some cancers with higher vitamin D, maybe a higher rate of pancreatic cancer. Some studies show less cardiovascular disease with high vitamin D levels, some find higher. So the Institute of Medicine was concerned based on the results of the contradictory epidemiologic studies, and that's why they really recommended levels less than 50.
Mm.
And so we've got this big range. So the best we can really say currently is just that there's varying opinions, and I would put myself in that 30 nanograms per milliliter should really be the cutoff, just for bone health.
You're thinking
And
that should
then
be the minimum.
I,
Mm.
to me, less
Mm.
than 30 would constitute deficiency, even
Deficiency.
just for bones.
Mm.
And then what is the optimal level? I have no idea. Anthropology might be able to help us a little bit here. So again, lifeguards can still get blood levels up about 65 nanograms per milliliter. So blood levels up to 65 are certainly still physiologically attainable. So it's one of those situations where it's quite possible that there's benefits to running that high, and that really is more of an optimal level. We all tend to feel good in the summer. We tend not to get URIs as much. Is vitamin D part of that seasonal stimulus, why we kind of feel depressed and cruddy in the winter, and then we feel like demigods in the summer? So that's certainly possible, but there aren't randomized controlled studies really demonstrating benefits at blood levels that high, because they haven't pushed the doses to achieve those blood levels. And so there's just a very big range. And again, there isn't even consensus really about what differentiates, sufficient from insufficient. And certainly there isn't consensus about what would constitute an optimal blood level. But, if we were looking for like something inoffensive, I don't think anybody would be offended by 40. Like, I don't know anyone on either side of the debate that would really assert that. Some would say, oh, that might be more than you need, or some would say, oh, that's still kind of suboptimal, but nobody would really be like upset at a blood level of 40. Not that the midpoint of consensus is necessarily the most correct or the best way to go about it. But that would be sort of
The
a
least
middle
controversial.
ground, perhaps, that shouldn't really offend anybody. And so if we're not able to get enough vitamin D from sunlight, then we would think about a supplement. And even in general, why would when would we want to take a supplement? Well, you'd really only want to take a supplement if it's something that you're just accepting there's no way for you to get naturally. If you're living in a northern latitude and it's the middle of winter, you're just not going to get a heck of a lot of sunlight. So, especially when we start talking about nutrients and vitamins, you can't just say this thing's good for you, so you take it by itself and expect it to work as well as it does in food. These vitamins are probably part of complexes. The food would be better than the supplement. So you can't just infer because something's good for you that you take it out in supplement form and it works the same way. That said, there are a couple supplements that if you just kind of accept that the way we live is creating widespread deficiencies, you might opt to supplement with that. And I'm sure we'll talk about all these in the future at some point, but you can make an argument for a fish oil supplement to get to get omega-3 fatty acids, because our fish are fed corn, which is bizarre, which has omega-6.
Very bizarre.
We're not really getting grass-fed beef. If you've ever, there's videos of fish eating corn, like these farmed fish eating corn, and it's
so
just
weird.
the most disturbing thing you've ever seen.
It's so weird. I wouldn't even think that they would eat it. Like,
yeah, they fatten
weird.
up the fish that way. So omega-3 deficiency, you might want to correct with like a fish oil or a krill oil. Fiber, that most Americans are eating very low fiber diets. Is that part contributing to our high blood sugars, colon cancer risks? So you can make an argument for a fiber supplement. Those are a couple of the supplements off the top of my head that there's just such widespread deficiency, or it would be really hard to get optimal amounts through diet or lifestyle alone. That's a time you might go for a supplement. But I wouldn't just you can't just pick any random vitamin and take a supplement and think it's the same as getting it from the food. You'd rather get your folic acid from green leafy vegetables than from the supplement.
Plus, then you're also getting the fiber and the other benefits, so
Exactly.
you kind of get more bang for your buck that way.
That's one of the problems.
Less expensive.
Well, but it's also just one of the problems with nutrition in general is really like the healthiest foods don't have a nutrition label.
Right.
you
Yeah,
know,
true, true,
and
true.
and
Ironically.
if we're subdividing foods into its parts, are we kind of missing the point? And really, that's one difference with sort of the nursing model. You know, when Chris and I are both alumni of Salem State College, now Salem State University. And at least when I was there, we were still Rogerian. Our nursing theorist was Martha Rogers, who was this
Mm.
like old chain smoking old lady
Yeah, they
talking
love
about
that chick over there.
nursing in space, and she had this raspy voice. But one thing from her theory of unitary human beings that is legit is that we as humans are more than the sum of our parts, that you can't just subdivide us and add it all back up together and get the same thing. And in medicine, we have all of these different specialties. So I do think there are lots of people who see the dermatologist for psoriasis and the rheumatologist for their psoriatic arthritis, and they take an SSRI antidepressant for their depression, and their vitamin D level is zero.
Mm.
you know,
Yeah.
and so is vitamin D deficiency potentially causal of those? And would it be effective as at least an adjunctive treatment for some of those conditions? So I do think there are people, and I guess in a sense, saying something like vitamin D deficiency, that's like a realer diagnosis than something like fibromyalgia, which is just restating that you have pain in your connective tissue in Latin.
And by the
Or,
way, we don't know why.
well, so I mean, if you're not if it's idiopathic and you're just kind of restating it, then that's how real of a diagnosis is that?
Right.
Not
And
that the
if I,
condition isn't real.
and if I'm not mistaken, fibromyalgia specifically is a disease of exclusion. You diagnose it by excluding everything else.
Well, so there are lots of exclusionary diagnoses where you just kind of rule everything out, and then you say, oh, and you might just be really
Mm.
uncomfortable because of this, or we've ruled out other causes, and then we end up at this funky neuromuscular. So there are times that we might benefit from a vitamin D supplement. Now, the American Academy of Pediatrics recommends 400 international units, IUs, of vitamin D for breastfed babies because breast milk doesn't usually have vitamin D in it, a lot of vitamin D, but
Hmm.
there's an important caveat there. So their reasoning was they use vitamin D in formula, but there's not a lot of vitamin D in breast milk. It's recommended, and this I do think is legit, that you keep newborns out of the sun because their sun is so sensitive at that age. So it's recommended to keep babies completely out of the sun for 6 months.
Hmm.
So the American Academy of Pediatrics recommends 400 international units of vitamin D for breastfed infants. However, Bruce Hollis did a lot of interesting research on vitamin D. And what he found, there were studies that found the
Hmm.
vitamin D status of breast milk is dependent upon the vitamin D status of the mother. And there
Would
have
make
been
sense.
cases where the mother, while pregnant, had severe vitamin D deficiency and babies were born with rickets. Just like if a mom has severe hypothyroidism, the baby would be born with cretinism. Like the baby in utero would be hypothyroid. That's why levothyroxine is one of the very few class A drugs. It's like proven safe in pregnancy. If the mom was hypothyroid, so would the baby. So
Hmm.
you would treat that and that would treat the baby in utero. So they did interesting studies that found that giving pregnant women or nursing mothers 6,400 international units of vitamin D raised the concentration of vitamin D in her breast milk and then was sufficient to raise the vitamin D level of the baby. So I thought that was very
Did
interesting.
he
Like a
find that
nut.
you would need higher levels of supplementation in the
Well, so
mother?
so 6,400 IU's is a pretty high dose. But
Okay.
that
Yeah.
raised the concentration of breast milk from 82 international units per liter to 873, which is
Oh,
actually like
okay.
about twice as much as formula.
Okay.
And so when they only use like this tiny little dose of 400 IU's, the breast milk level barely went up from
Hmm.
45.6 to 78.
Okay,
So
interesting.
another option of treating vitamin D deficiency in breastfed babies would just be to give a high dose supplement to the mother, which will then make its way into the breast milk and eventually to the baby.
There you go. Just go further up the train.
So I thought that was actually kind of cool. I thought that was really interesting research by Bruce Hollis. So I'd like to give him a shout out. I thought that was very cool research.
Good job, Holly
So
boy.
yeah, he hates being called that, by the way. We actually exchanged an email once. He seemed very nice. But just something a lot of people don't know, you can email people who do research, and usually they're very glad to get an email from you
Hmm.
because it makes them happy that people are taking the time to read their research. I've conversed with a couple Nobel laureates actually, and why? Because I sent them an email, and I guess it was moderately charming. So you got to just have the gumption to go for it. But yes, give props to Holly Boy, this this person with a doctorate, and now he's become Holly Boy.
He will forever now be known as Holly boy.
Yeah. Let's see if we have that power. So again, 400 IUs is the dose that's now recommended for infants. And we don't really know what would be the optimal supplement level. But what is very important to understand is there really isn't a toxic supplement level. There is a toxic blood level.
Mm.
And like we said before, people with darker skin, people who are obese might need very high doses. Vitamin D metabolism is odd. The people's reaction to it varies for reasons that aren't well understood and are probably genetically coded. Like 2000 IUs doesn't create a uniform increase in blood levels, and you actually tend to get greater increases with the first amount, and then it's not perfectly linear. Like you, in other words, like 1000 IUs is likely to raise your blood level more than then going from 1000 to 2000. Like the increase from 0 to 1000 is likely to be greater than the increase generated from going from 1000 to
So
2000.
proportionally, you're saying they're not proportionate. Yeah.
Exactly, it's not
Yeah.
perfectly
Yeah.
linear or anything like that, and that does make this tricky as well. And so the Institute of Medicine set 4,000 international units per day as the tolerable upper intake level. And that means the amount that they believed has been proven safe. Now, some studies showed no harm with doses up to 10,000 IUs. That's what the Endocrine Society used as their upper limit. But the
Mm.
Institute of Medicine, concerned with blood levels above 50, they found, well, 5,000 IUs can get you up to 60, but really no farther. And so that wouldn't push anybody beyond physically, like physiologically attainable levels. Then they applied an uncertainty principle of 20, and that's how they ended up at 4,000 IUs. So, you know, there's nothing wrong with that recommendation, but there are people who would need doses above that to get therapeutic blood levels. And just if we kind of think about it in general, when you have something like a tolerable upper intake level, this one recommendation that's meant to apply to everybody over age 9, without really factoring in skin pigmentation or latitude or weight, uh, it's just worth remembering that a recommendation as generalized as that,
Mm.
it shouldn't be elevated to like a religious status or anything like that. There
Hmm.
has to be some crudity of that value.
Hmm.
But you could see how if you don't really know where that was coming from, and then somebody's taking 5,000 IUs, you'd be like, oh my God, what's wrong with you? That's above the tolerated upper intake level. But that 280-pound person might not even get a heck of a lot of bump from doses as high as 5,000 IUs. So they really need to be supplemented and then have blood tests redrawn 3 months later to then see what effect that level had, and they might actually need much higher doses.
Mm. Interesting. Okay.
So again, whenever you're making like population-wide recommendations, it's worth remembering that they must be somewhat arbitrary. And just because some committee made this recommendation, that's a good starting point. But that isn't law, and that really shouldn't be elevated to anything more than a generalized recommendation.
Well, it's very
Now,
difficult because not a lot of research is done so population specific. Like they want to find that therapeutic or that intervention that's going to work for the general population, but that's very difficult to do.
well, again, one of the strengths of America is that we're heterogeneous.
Mm.
So what
True.
a 9-year-old
Mm.
Caucasian light-skinned person living in Florida is going to need is going to be very different than an African American heavyset person living in Chicago. But it is worth remembering that the recommended daily allowance and the tolerable upper intake level are thought to apply to both. So there is just some crudity in a value like that.
Hmm. Hmm.
So RDA, recommended daily allowance, that's thought to be the daily level that is sufficient to meet the nutrient requirements of almost all healthy people, like 97 to 98%. That's what's like 100% of the value on the nutrition label.
Sure.
And so that's the amount that was thought to be, would prevent deficiency. And you could certainly argue the IOM was a little bit too low on that as well, using that 20 cutoff. And then the tolerable upper intake is the maximum daily intake unlikely to cause adverse health effects. And that they set at 4,000 IUs. But certainly doses up to 4,000 IUs are thought to be safe. And certainly if you were doing randomized controlled studies, I certainly think we should be pushing the levels higher, especially for secondary prevention for treatment, up into that 4,000 IU range. And we'll talk about that a little bit. So um, again, there's no set, toxic level or toxic supplement level. There's a toxic blood level that's kind of difficult to achieve. And even very conservatively, 4,000 IUs in general has been proven safe. There are some specific contraindications to vitamin D, like in sarcoidosis or primary hyperparathyroidism. That's why we're only talking about things on sort of a general population level, as with anything. However, in general, it really is thought to be very safe.
Would there be different guidelines for time of the year? Because, like you mentioned, we're out more in the summer.
Well, that's
Would you?
another, kind of tricky thing to debate. Now, just in general, when you're talking about a supplement, if I go swimming at the pool, I'm probably not going to take my vitamin D supplement here in August.
Mm,
I got my vitamin D. In general, supplements, they're not drugs. If you miss a day or two, it's not the end of the world. You're just kind of saying, oh, I think I would benefit from putting a little more of this into my body. Most vitamin D researchers recommend just taking a steady dose, but it is fair to say,
mm.
should we sort of increase our dose a little bit in the winter? So when people are supplementing, the best bet would be to know your vitamin D levels, start supplementation, and then get retested 3 months later to sort of see what effect it has. And then actually titrate, adjust the amount based on the vitamin D level. But a lot of people actually recommend aiming for a steady vitamin D level. But it is fair to take an anthropologic approach and say, well, maybe nature expected our vitamin D levels to kind of shift.
Right.
Or so there are people who
Mm,
might take 1 to 2,000 international units during, most of the months, and then they double that, or they take 4,000 IUs during the winter.
mm.
That's one thing that it's not, there aren't randomized controlled studies to kind of guide us longitudinally
Right.
looking at health outcomes. So that's a fair controversy in vitamin D. I typically just take a flat dose personally. And I would be more cognizant of taking it in the winter than in the summer.
Hmm, interesting. Yeah, because I've generally gone by the principle. I've been doing about 2,000 a day in the summer, and then in the winter months I bump into four.
Which is reasonable.
Yeah,
And again, unfortunately, there aren't randomized controlled studies to
yeah.
kind of
It'd be
guide us.
interesting to
So
look at
we're all
that.
just guessing a smidge. But the Endocrine Society really felt like you would need 1,500 to 2,000 IUs per day of vitamin D for adults just to get us to that blood level of 30. So I
Hmm.
do think in that 1 to 2,000 range, we're talking pretty darn safe levels for the average person.
Hmm. For sure.
All right. And then I know you wanted to talk a little bit about sort of a hot button topic at the moment. So there have been some studies recently linking vitamin D deficiency with COVID. And that's something I know you recently dug into.
Yeah, I mean, obviously, everyone's talking about COVID these days. Everyone wants to know what's going on with this virus. How can we treat it? What should we be looking at? And interestingly, vitamin D is one of the stones we've been turning over in terms of this research. It's definitely a hot healthcare topic of the day, hence why we're talking about it. But one of kind of the, speaking of epidemiology, the NIH study that I looked at, it was a meta-analysis, which was great. So looked at a number of different studies across the board, looking at different vitamin D levels and comorbidities of people that are having severe, mild, and moderate reactions to COVID-19 disease. So basically what we're trying to tease out here is vitamin D play a role in this. And some people seem to think it does. Some people think it's a confounding variable. So how do we tease that out? So number one, what are the kind of things that we want to look at? So we want to look at things where vitamin D has an effect on various systems in your body. As I talked about a little bit earlier, they have done lab studies where we can see that vitamin D has a regulatory effect on the renin-angiotensin system, which for people that don't know, is one of the mechanisms through your kidneys that help regulate your fluid volume in your bloodstream, and kind of as a secondary effect of that, your blood pressure, right? This is one of the mechanisms we can kind of take advantage of with people with blood pressure. We can help regulate the system with medications and kind of help modulate that, bring down that fluid volume, bring down people's blood pressure. So we've seen in lab studies that vitamin D can actually have a regulatory effect on this system to kind of naturally help regulate this fluid volume and help with blood pressure. So that's number one. Number two, we also see in terms of your immune response that the active form of vitamin D that Dan talked about, this kind of steroid hormone form of vitamin D, also has an inhibitory effect on your immune response in terms of inflammation. We've seen that in laboratory studies. So the reason why this is so important when we're talking about our discussion of COVID-19 is the most severe cases, the people that are ending up in the ICUs, the people that are having very severe outcomes and sequelae afterwards, are having this, what they're referring to as a cytokine storm. You may have read about this a little bit. And basically, what is a cytokine storm? So cytokines are similar to hormones in that they're chemical messengers, but they're more specifically chemical messengers that have a localized effect on your immune system. So think about them that way. So when these cytokines kind of go crazy, we're basically putting our immune system on high alert. And when we talk about things like cytokine storm, we've overcorrected, so to speak. We're going too far. The immune response has gotten out of control. So then the question becomes, does vitamin D play a role in helping to inhibit that effect? Can it be potentially used as a therapeutic? Or if not as a therapeutic, does people's vitamin D levels have almost a predictive mechanism to what their outcome will actually be? So we looked at a couple of different studies. One was a really great NIH study, which was a meta-analysis of a number of different papers that have come out. And mind you, researchers are kind of scrambling right now. They're trying to come up with as much data as they can, analyze it as quick as they can, because obviously this is a global pandemic. We're all very worried. We all want to kind of find the best answers as we can. So one of the things that paper showed was that amongst people that had severe disease, as defined by their clinical course, people that ended up needing ICU care, intensive care, or artificial ventilation, among these people, they found to have levels of vitamin D that, as defined, even though Dan said there was some kind of controversy about what the actual sufficient levels are, what constitutes deficiency, even among those definitions, a large percent, we're talking about, I want to say over 83% of people that ended up in the ICU had what we considered vitamin D deficiency. Okay, great. What do we do with that number, right? And we say right there, okay, clearly vitamin D plays a role in this. Well, no, we can't, because as we've been talking about all day, correlative data does not necessarily mean causation. And I would also point out that amongst this same cohort of patients, comorbidities like cardiovascular disease, hypertension, diabetes have all run rampant. But interestingly, Dan, right, these are also comorbidities that are highly associated with vitamin D deficiency, right?
So again, is this a marker or is it causal?
Is it a marker? Is it causal? Is there low vitamin D levels playing a role in their clinical course? Or is it just indicative of the fact that they have these other conditions that are also associated with low vitamin D? Okay. So that to just give you some context of the situation. So then the other study that I found very interesting was the one that you actually said to me, Dan, from the hospital in Italy. Okay, so what was very interesting about that was among the cohort of patients that ended up with severe disease, needed ventilatory support, ended up in ICUs, a high percentage of them were below, I want to say it was 10 nanograms per milliliter when they actually ran the vitamin D studies. And interestingly, the next cohort up, which was at that 20 to 30 level, which is most accepted to be in the sufficient, depending on who you ask, in the sufficient range, you're talking about a difference of 95% having severe vitamin D deficiency, leading to a severe clinical course, even high percentage of fatality, versus only 5% of patients in that sufficient level of vitamin D having more of a severe course. So break that down. People with levels of 10 or less ended up with severe disease in the ICU up to the tune of 95%, 85 to 95%, whereas people with sufficient levels only ended up with a severe disease course to the tune of 5%. So that's a pretty big difference. So you can see why this is such a controversial topic right now. It's something that obviously needs to be looked more into. So now a little bit about, okay, so should we start pumping large doses of vitamin D into these people? Unfortunately, those studies have not been done yet. Those therapeutic studies, those double blinds, they have not been done yet. I imagine they will be done in the near future. But again, is that going to be enough? Is it going to be enough to supplement their vitamin D in large, fast doses when they've already had the severe clinical course? Or is the moral of the story that we should really be trying to correct these levels before people get into these states of severe disease? Because I
And
think
there are some studies actually showing that vitamin D supplementation helps decrease the risk of upper respiratory infections in general. I don't think we're
exactly.
there on COVID yet, but there's plausible mechanisms in play at
We're
least.
not there on COVID yet, but I'm glad you mentioned that, because that was actually gonna lead to my next point of discussion. Some of the studies I'm reading when it comes to more generic forms of respiratory disease are finding that in terms of their vitamin D level, the people that had adequate levels of vitamin D going into a respiratory infection or condition fared better than people that went into it with a lower vitamin D level, but then were supplemented during their disease course. So it didn't so much help those people to supplement and get them up to a sufficient level of vitamin D while they were experiencing their acute respiratory illness, as opposed to the people who already had a sufficient level going into that illness. So there is some precedent to be said that maybe you're almost a little bit too late to the scene when it comes to this vitamin D stuff. But again, correcting for things like diabetes and underlying heart disease, we would obviously have to tease that out too, right, Dan? Because those become what we call confounding variables. So again, to kind of frame it, are these disease courses being led by their low vitamin D levels, or is it by these comorbidities also associated by low vitamin D levels? And to add another layer of complexity, are those underlying conditions being exacerbated or caused by low vitamin D levels? So it's really way too early to kind of tell. But that being said, I think it's encouraging. I think what we can infer from this is, even if the vitamin D is causative or not, or can be used as a therapeutic or not, there's clearly a role vitamin D is playing in these conditions. We are seeing people having less incidences of these cytokine storms and having a less severe disease course when their vitamin D levels are considered optimal. So there's certainly enough compelling data to look into this further. Now, some of the limitations of these studies, like I said, people are trying to do as much data collection and as much analysis as fast as they can. The studies are just far too limited right now, right? The sample sizes are low. It's hard for them to correct for certain environmental factors. All these studies are basically using a convenience model because the patients are there. They can't really select to kind of tease out some of those other variables. It's not a controlled laboratory study. So it's not exactly the most ideal data to be working with, basically, was what I'm trying to say. But there's at least for pathways and potential for future research, which is absolutely great.
There's definitely, in my opinion, at least enough there that they should be doing randomized controlled studies using vitamin D as an adjunctive treatment. And even just based on the existing data, at least to me, there are stupider ways to
Right.
try to prophylax against both
Right.
getting COVID and then getting cytokine storm and more severe disease
Right.
than vitamin D supplementation. So
Right.
that's sort of the debate. Again, that association versus causation. And is this just a useful as a marker? I definitely think it has been, or is this actually causal? And I guess randomized controlled studies would elucidate that. But you also hit on another important point that just because vitamin D would prove insufficient when treating a disease as secondary prevention, I would not infer from that that it's not going to be effective as primary,
Right.
especially because a lot of studies just wouldn't run long enough to catch primary benefits. So I'd like to talk actually a little bit just about a couple studies that have done randomized controlled studies. Again, we still don't have randomized controlled studies using vitamin D as a treatment for COVID or cytokine storm.
Right.
I mean, it makes more logical sense to me than hydroxychloroquine and azithromycin.
Well,
To
just
me,
about anything at that point would
you know,
would be better. I
um,
mean, we could throw
and,
cyanide
and
at these people would be better than
well,
hydroxychloroquine.
well, no, what's funny, NIH stopped that study early, the ORCID study, but
They
it
did,
didn't
yeah.
find evidence of harm.
Right.
Usually you stop a study early if it finds evidence of harm, not just because you're like, oh, I don't think this is going to be efficacious. And I've had a hard time finding the raw data from the ORCID study, which is odd. But
Hmm.
yeah, I mean, not randomized studies have not teased out a benefit from
Well,
hydroxychloroquine.
in that study, were they only specifically researching hydroxychloroquine? Because I remember when this started to come out about the use of this drug, it seemed like most protocols were pairing that with a Z-Pak, so 5 days of zithromycin. And I don't know if the two were being proved to be more efficacious than any one of them alone. And have they looked at that?
So some studies have studied just hydroxychloroquine, some have studied hydroxychloroquine and azithromycin. And now, at least the people in the pro hydroxychloroquine camp, it might be a tale of shifting hypotheses, are now saying, well, you have to supplement with high dose zinc initially too, or it might have
Okay, I heard a
efficacy
little
for
bit about that
mild
too.
illness but not
Yeah.
hospitalization. So again, they've done a handful of randomized controlled studies, but there have been some quality control issues, and again, lots of like preprint
Right,
case
right.
reports and retrospective case control studies that are kind of
But
fuzzy.
bottom line, it would seem that hydroxychloroquine alone is not proving to be effective.
But randomized controlled studies haven't teased out a benefit, and
Right.
it's very bizarre that a drug would be touted as a game changer prior to there being randomized controlled studies.
Right,
So
right.
was that just sort of presumptive to make it look like the government was doing something and subsequent studies failed to find efficacy? That's the camp I would fall in. There are
Right.
others who would assert, oh, there's a conspiracy that, because it's this cheap drug, they don't want to find efficacy. Uh,
Well, you could
that's when,
dispel that right away. They found efficacy with dexamethasone in
well,
calming
that
down cytokine storm,
dexamethasone's really
which
cheap.
is really cheap and really old as well. Like,
So dexamethasone's a corticosteroid that
right.
reduces inflammation. One of the benefits of dexamethasone is it lasts for about 72 hours, so you only need that one
And it's very
dose.
potent.
And it's a very strong anti-inflammatory corticosteroid. So yes, it wasn't like here's our new patented drug,
Right,
or here's
right,
like an enantiomer of an hydroxychloroquine, just the
right.
left-sided molecule or something like that. So to me, I just haven't seen any efficacy for it. And even based on existing data, at least there's dumber thoughts to try to prevent the illness in general or the severe disease than vitamin D. And again, vitamin D would be unlikely to be sufficient in and of itself if you had a prolonged exposure to get it, but might you
Hmm.
have a more mild illness and
Right.
less likely to develop severe disease if your blood level 60 than over 10? I guess we'll find that out, and hopefully
Yeah.
they'll do randomized studies, and I hope they push the doses. So that's just the point I want to take away from that. Researchers have done randomized controlled studies using vitamin D, but there are some problems with them. So I have an issue sort of with some of these studies. So a lot of the studies used very low doses of vitamin D. They didn't use an oil-based gel cap, so it wasn't in a like bioavailable form.
Right.
So those are really some of the knocks I have with some of these studies. So I'm
And
going
what
to
kind of
try to.
disease population were they studying this in?
They usually study it in healthy people, or they've looked at it in specific settings. So forgive me,
Okay.
I'm gonna make that unappealing face again, where I try to like figure out
Wait.
how to share screens here. So I just want to look at. Doo-doo-doo. All right. So one study in particular that I just want to, I guess, criticize a little. So there was in the aughts, they did a couple big studies looking at calcium and vitamin D
The odds.
for
I love that.
breast cancer, for risk of fractures, colon cancer. And to me, I think the abstracts were a little misleading and made it sound more negative than it was. So, calcium plus vitamin D supplementation and the risk of fractures, published in the New England Journal of Medicine 2006. The full text is available online. It was using postmenopausal women. And what it concluded was among healthy postmenopausal women, calcium with vitamin D supplementation resulted in a small but significant improvement in hip bone density, did not significantly reduce hip fracture, and it increased the risk of kidney stones. So if you just read the abstract, you'd really walk away from that feeling very negatively about it. The problem is they only used 500 milligrams of calcium with 200 international units of vitamin D3 twice daily. And in general, you don't want to take calcium. I'm not a big proponent in general, but you don't take more than 500 milligrams of calcium at a time because you don't really absorb it. So you would get better absorption with 500 milligrams twice daily than 100 milligrams once daily. But the total dose in these adults was only 400 international units, which
Hmm.
is now the dose recommended literally for infants, and it wasn't in an oil-based gel cap. And even still, it didn't significantly reduce hip fracture. It didn't reach statistical significance, but it did reduce hip fracture. Among women who were adherent, meaning those who took more than 80% of the meds, it resulted in a significant 29% reduction in hip fracture. The older women, those over 60, it reached statistical significance. And the study turned out to be a little bit underpowered because they didn't actually have as many fractures as they thought. And so to me, the abstract seemed a little bit misleading. And calcium supplements, when taken by themselves, they have been associated with an increased risk of myocardial infarction because calcium makes up part of that plaque that can goop our arteries, causing
Hmm.
atherosclerosis. So I'm sort of in that camp that for most people, the problem isn't insufficient calcium, especially if you eat dairy, because you
Well,
could
not even
argue
just
maybe
dairy. There's so many dietary
well,
forms of calcium.
green leafy
A
vegetables,
ridiculous amount.
so you would really think that our
Could
bodies
like fall
weren't
down
really
backwards and fall into some calcium.
meant to run on that much calcium were we with optimal vitamin D levels. Um, so to me, the abstract painted it a little bit more negative than it actually was. And
Yeah.
so that's the biggest criticism, though, that I really have with a lot of the randomized controlled studies is they were just underdosed. You only get something like a 2.5 to 5% increase in vitamin D levels in adults from 400 international units. That's not really enough to move the needle. So a lot of studies that had negative findings, the biggest criticism I have is just that they were underdosed. And I'm
That,
going to try to
that's a,
skip
that's a
ahead
pearl
here.
right there, BSN students. You got to read past the abstract. I mean, that's good advice for anyone, but
Well,
particularly BSN students, read past
all
that
right.
abstract.
Now, there was a study, this is the one I referenced earlier, where NPR and
Oh, yes,
Yahoo
the
had
vital
very
study.
different interpretations. But the VITAL study, done here in Boston, so it studied 2,000 IUs of vitamin D3, which they called high dose. Now, relative to 400 IUs, that's, yeah, but I certainly wouldn't call 2,000 IUs high dose. 4,000 IUs is a pretty good dose. 10,000 IUs, I'd call that high dose. And that's something that is important. It's important that our beliefs are falsifiable. In science, a hypothesis should be able to be proven wrong. So I'm sort of asserting that a lot of negative studies, in my opinion, used insufficient dosaging, and that's why they've been somewhat underwhelming. If 4,000 IUs fail, that would make me rethink my hypothesis. I would say, that's enough that I really do think that should have been doing something. Maybe it is just association. So But it studied 2,000 IUs. That's not a bad dose, with or without fish oil, compared to placebo for a median of 5.3 years. So
Hmm.
it did not reduce the risk of cancer, nor did it reduce the risk of major cardiovascular events when they were all bundled together. You took heart attack, stroke, and cardiovascular death and stuck them together. And this 2000,
Okay.
well, and that, to be fair, sometimes in studies, they do use these combined endpoints.
Yeah, it's just very
Uh,
different disease courses.
well, but also with these combined endpoints, sometimes prospectively, I feel like it's almost like cheating because it makes the number to treat lower. It like makes the statin looks like it does more
Yeah.
because you grouped all these different outcomes together. But most participants got blood levels up near 40 from 2000 IUs. Yet, normal weight participants got suggestive, which is the term they were using to mean significant, reductions in both cancer incidence and mortality. And if we know that overweight people might need much higher dosages, like 2 to 3 times, was that dose of 2,000 IUs insufficient for them? African Americans, again, with a higher risk of vitamin D deficiency because of the pigmentation of their skin, had a 23 production in cancer incidence.
23%? That is absolutely significant.
And overall, even though the vitamin D didn't statistically significantly reduce cancer incidence, there was a reduction in cancer deaths. So again, why we have needed a longer study of, if you're going to do a longitudinal study looking at cancer incidence, that might have to run 15 or 20 years to really catch that kind of
Right,
benefit.
absolutely.
But there was a reduction in cancer death. So does vitamin D help with apoptosis, programmed cell death, or does it improve macrophage function so you're catching cancers earlier, in some way inhibit metastasis? Those are still unanswered questions. So even this study might not have run long enough to capture those primary prevention benefits, and was still not a heck of a giant dose.
Yeah. Interesting.
All right. So I think we've done a
5.3 years. Okay, interesting. Wow.
well, no, I mean that sounds like a long time, but actually,
Not
when you
not
do,
really for long disease
it's
courses like
not.
these. Yeah.
And when you do a study like that, you actually have to exclude cancer and heart disease events that happen within the first couple months, or even sometimes like the first year or two, because you say, oh, well, that's not because of the disease, that was pre-existing. So it's tough to, again, the longer you run a study, the less adherence there'll be, the more drop off. There are lots of logistical challenges. I'm not trying to be overly critical. I think this was a pretty well designed, well intentioned study.
Right.
But you would need to follow that longer potentially to get the primary prevention benefits.
Yeah, definitely. Very, very interesting though.
All right, shall we move along? I think we've done a pretty deep dive
I
here.
think we've done a pretty good job here. I think I think we definitely established that there's some compelling data and definitely more research potential.
And again, there's so many diseases associated with this: colon cancer, type 1 and type 2 diabetes, a lot of autoimmune diseases. Just those fundamental issues of whether it's causal or not, in my opinion, remain unanswered, because the studies that would establish it, the randomized controlled studies where you take two groups, you try to make them as even as possible, you give one just an oil-based gel cap with no vitamin D, you give one an oil-based gel cap that has vitamin D. The researchers don't know, the participants don't know, it's double-blinded, and then you follow health outcomes. Those kinds of studies used insufficient dosages. So I think you would need to do those studies with higher doses to capture benefits. On the flip side, you can see how some would say, look, we've done this study already, but 400 IUs is just not going to move a needle in an adult. So some final thoughts here. So if supplementing with vitamin D, I would definitely recommend D3 over D2, and take it in an oil-based gel cap for better and more consistent absorption. There's a clear consensus that less than 20 constitutes deficiency. There's debate over the lower level. Should it be 20 or should it be 30 for overt deficiency? I would fall into the 30 camp if you choose to listen to me over the Institute of Medicine, which might not be well advised. You'll get to know me. You'll get to know us better in subsequent weeks. And just to be blunt, the optimal levels of vitamin D are completely unknown. So on some level, we're just kind of deferring to expert opinion, whether that's the IOM or individual physicians. So William Davis, again, he's a preventative cardiologist. He wrote Wheat Belly. He has a really good blog, the Wheat Belly blog. I do tend to think very highly of him. He recommends blood levels of 60 to 70. The Vitamin D Council says 40 to 60. They actually have a lot of good research too. It was started by a doctor, Dr. John Cannell, who, if I'm recalling correctly, he's a psychiatrist, but he was supplementing his psych patients with vitamin D. Again, it might vitamin D play a role in depression and seasonal affective disorder. That seems perfectly logical. And his patients were all being treated with vitamin D because he used it as an adjunctive treatment. But there was a flu outbreak at his hospital, and he noticed that like his patients didn't get influenza, and that led his interest into vitamin D. The Institute of Medicine specifically expresses concerns with levels above vitamin D because of those contradictory epidemiologic studies and the potential increased risk of pancreatic cancer. And to be fair, pancreatic cancer is about as yucky a diagnosis as you can get. Lifeguards can still achieve levels up to 65. So up to 65, we're still definitely in the realm of physiologically attainable. And the lowest level that would be potentially associated with harm that I've seen is 88. And a lot of places use levels as high as 150 or 200 to constitute deficiency.
Yeah, the
So,
one study I think in that one from Italy categorized it as 75 or above, but I think again that was being conservative.
yeah. And so even still, we're talking about a very wide therapeutic index. So
Absolutely.
again, trying to sort of generalize here, like what would be inoffensive recommendations? Even if someone's vitamin D status is unknown and they were a believer in vitamin D just for optimal health, something like 1,000 to 2,000 IU's per day,
Bare
to
minimum.
be extra conservative, 1,000, taking a do no harm approach
Yeah, bare minimum.
and aiming for levels of at least 30 for bones. And you could potentially need twice as much. Like optimal level might actually turn out to be more like 60 or 65 to get those extra skeletal benefits, but that still hasn't really been established. So, how could we go about sort of answering some of these questions? What would be some suggestions for future research? So, studying vitamin D3 as an adjunctive treatment should be easy. You take the current recommended treatment and you add vitamin D3. You take an SSRI and you give one group an SSRI and just a gel cap full of medium chain triglyceride oil. And you take one group and you use an SSRI and you give them 4,000 IU's of vitamin D3 in a gel cap of medium chain triglyceride oil. Measure the client's vitamin D, that 25 hydroxy vitamin D at baseline and 3 months into treatment. That'll tell us if it's actually generating an improvement and what level we got them up to. That we need to use higher doses. In a perfect world, and this is getting complicated, but what would really kind of tease this stuff out? You study placebo versus 2,000 IU's versus 4,000 IU's versus 10,000 IU's. And then you could also design studies that don't use a set dose, but instead use a protocol that titrates the dose to achieve a various level. So you have a control group, a group you titrate to over 20, a group you titrate to over 30, over 40, over 50, over 60, and then you follow health outcomes.
And I think you would get the most benefit out of that study because, like you said, a dosing can be adjusted for a person's weight. Obese people, like you said, with it being stored in the fat, would obviously need much higher doses. So ultimately, in terms of therapeutics, I think aiming for a specific target blood level makes so much more sense.
And again, it's one of those, if we aren't fully storing vitamin D up until levels of 50, well, there might not be a heck of a lot of difference between 30 and 35 or something like that, but then there would be a real big difference up above 50. So it is kind of challenging just with the IOM specifically expressing concerns with those high levels, and yet others really asserting we don't even store vitamin D until those levels. There might somewhere be in there, like you wouldn't expect perfectly linear benefits, that there's kind of a cutoff and there's a big difference between the level where we actually store it and a level where it's being used as quickly as it jumps in.
Yeah.
So again, I wouldn't really anticipate perfectly linear relationships. Like there might not be that big a difference between 30 and 40, but there might be a big difference between 40 and 50 or something like that.
Definitely.
All right. And so, just to sort of circle back, I guess, to the fundamental conflict, I think part of why vitamin D is so controversial is that there's two opposing but logically valid interpretations. Uh, People could logically say, yes, vitamin D is associated with all these things, but that doesn't equal causation. It just has usefulness maybe as a surrogate marker, and we should fix overt deficiency, but there isn't really compelling evidence of those extraskeletal benefits. Randomized controlled studies haven't really borne out that there's benefits. And just in general, every 20 years, there's some new miraculous vitamin that's going to cure everything. On the flip side, if we have this known homeostatic imbalance, if we have this deficiency that's known to be associated with a disease, and there's a probable or at least plausible mechanism, should we logically fix that deficiency really even prior to starting drugs that would have a worse side effect profile? Before you're starting in on immunosuppressants or things like that, should we start by actually correcting the known imbalance? Or at least do that as part of an adjunctive treatment? That vitamin D has been proven safe up to 4,000 IUs. That's a really conservative recommendation for the IOM. And that maybe the randomized studies have been underwhelming because the clients were underdosed and or it wasn't in a bioavailable form. And so the sum of all the existing data together, since we're always making imperfect decisions based on what's known to us at the time, it's not really a matter of being right, objectively correct, like there's one objective truth all the time, but sort of looking at the best data we have and making a judgment that the sum of the existing data would support supplementation. And so that's the fundamental conflict that remains, but at least now hopefully it's more clear why that is and why there's opposing recommendations, and now you have a deeper understanding of vitamin D and can make an informed decision.
Absolutely. I think if anything, the takeaway here should be, it would be my hope that people realize how potentially important vitamin D is in the regular homeostasis of their body. I'm hoping regular people that might stumble upon this podcast might be able to start taking more notice, maybe even looking into getting their levels drawn by their primary care doctor, starting some form of supplementation. And maybe even for some of the more expert level people that might be consuming this podcast, maybe we help them think about it a little bit more differently. Maybe help them think in some new directions, which is always the hope. If we can just help spark ideas, we're doing our part.
And just kind of forwarding a discussion,
Absolutely.
and so people can feel free to comment, and I'll try to be responsive to that and start a discussion going about vitamin D a little bit, because I'm a believer in it, but I do think I would be willing to have my belief change based on existing data. I'd love to see the results of randomized controlled studies that are
Absolutely.
using those higher doses, like 4,000 to 10,000 IUs.
You'll-
And were those to fail, that really would make me sort of second guess my reasoning.
And I think in this realm, you always have to be willing to interrogate your assumptions, right?
Well, science, we're supposed to do that in general. We're supposed to be able to really vehemently contest ideas without being personally offended. But science isn't pure or pristine like that. But I do think it's important to highlight that people who would have come to a different conclusion on vitamin D, the people who are like, oh, they've done randomized studies, it really hasn't borne out anything.
Right.
I'm not disdainful of that opinion. I do think that's a logically valid interpretation. I'm sure as the weeks go on, I don't have a great poker face, right? Like next time, I think we're planning to talk about type 2 diabetes and blood sugar. I'm sure my disdain for the people who disagree with me will be evident.
Yeah.
I don't feel that way about vitamin D. There is a fundamental conflict because there's a lack of, in my opinion, quality randomized controlled studies that use the appropriate dose in a bioavailable form. until those studies are in, there's going to be debate, and people could logically fall on either side of that. So I don't think lowly of them or anything like that. This isn't one case where I'm like, I'm right. I really think I'm right and everyone else is wrong. We'll get there, I'm sure,
Right.
but not this week. Vitamin D is kind of tricky. So at least now we've put it into context and identified some future avenues for research and touched upon its potential effects in COVID and potential use as prophylaxis, both for the illness and severe disease. And, really, I would say a pretty urgent need to do randomized controlled studies. And I think they should really push those doses up to 4,000, 10,000 IUs if you're hoping to get like an acute anti-inflammatory immune modulating effect on existingly ill hospitalized clients.
So absolutely. So just some housekeeping stuff. So just a quick message to the audience. So what can you expect out of Two Nurses One Podcast in the future? As Dan said, coming up, I think our next big topic is going to be type 2 diabetes. So as a little bit of a teaser, we're going to kind of try to make the case that type 2 diabetes isn't a real disease. So if you're interested in that conversation, maybe you want to learn more about type 2 diabetes or just get a new perspective on it, certainly pay attention for our next podcast. Also, I do want to say thank you so much for the people that made it this far through it. We know we're still tinkering around a little bit with the production stuff and the formats and things like that.
We're working
so definitely,
on a jingle.
We're working on title screens and a jingle. So,
like a classic 80s sitcom intro and outro.
Oh, I would love a synth, something with a synth. Yeah, absolutely.
We burn a pizza in the oven and look at each other like, oh, Chris, you burned the pizza in.
Yeah, so it's going to get better. I can make a personal promise and dedication to that, doing a lot of the back end stuff. And it's stuff I want to learn more about anyway. I mean, we're a couple of nurses. We geek out on nursing and healthcare stuff. So absolutely, if people are interested or have topics they would like to see us go into a little bit more, we're absolutely open to suggestions. But I think we have a pretty good pipeline of stuff going forward. So definitely there's exciting things on the horizon. Please just give us some leeway to kind of smooth out the rough edges there. So, Dan, any final thoughts on vitamin D?
Yeah, I mean, I think we hit on all the big stuff. So now we're just believers as nurses and in general in informed consent, that we as healthcare providers are supposed to explain these concepts and give potential options, and then we respect people's autonomy to make their own decision. But how can people make informed decisions without really having a deep understanding? And so hopefully we've sort of deepened your understanding of vitamin D deficiency and why it is so controversial, and now you can go and make the decision you think is best for you.
Absolutely.
If you've done that, then we've done our job.
Absolutely. Well, listen, Dan, it was a pleasure. I look forward to the next one. And everyone out there watching or listening in whatever format you're getting this on, thank you for taking the time, and we look forward to seeing you guys in the future. As for Two Nurses One Podcast, I think we'll be signing off for today.
All right, bye guys.
Good night.